Today, we touch on a topic that we haven't seen here yet on this podcast. Donna is an expert in eating disorders and how to treat from a functional approach. We also ask, where do we even draw the line with being proactive about your health and health practices and developing orthorexia, which can really be of concern in our industry?
Yes, we want to be careful of that one. So I'm glad we talked about orthorexia today, Melissa. And I also particularly found it very valuable that Donna spoke to testing sex hormones, adrenal function, and nutrient status for individuals with eating disorders, which is going to be such a pivotal and important piece of their treatment plan. So let's not waste any more time. I think it's a great episode. Let's get to it. Hello and welcome back to the Vibrant Wellness Podcast. I'm Dr. Emmy Brown here with my co-host Melissa Gentile. Today we're exploring how to apply functional nutrition to address eating disorders with our very special guest, Donna Galarza. With 46 years in the medical field, Donna is a dedicated medical nutritionist whose approach integrates cutting-edge nutritional science with personalized care to tackle the root causes of health issues. Join us as Donna shares her insights on eating disorders from a physiological perspective and how to use functional nutrition as an underappreciated yet truly holistic approach to eating disorders in today's episode. Hi, Donna. It's so great to have you here. Welcome.
Thank you so much for inviting me.
Sure. We're so excited to jump into this topic. We haven't talked about it before on the podcast, and I think that it's really important to talk about, particularly in the wellness field. I'd love to know, Donna, how do you explain the difference between functional medicine's approach versus conventional medicine's approach when it comes to treating eating disorders? What's not addressed with the traditional approach?
Okay, so when people come to me and I would assess them and determine their level of care, if I could work with someone on my level, which means the symptoms are not severe and they're not way underweight, a BMI below, say, a 15, I can work with them at my level. But if they need to go into an inpatient or intensive outpatient facility, usually inpatient, then when they go in, the facilities are assessing them for, of course, their eating disorder issue as far as what's their weight, their BMI, those types of things. Are they bulimic? Are they anorexic? Are they using laxatives? They would also apply the mental health piece, which are they suffering from comorbidities, anxiety, depression, OCD? But what I had noticed over the 15, 20 years that I've been doing this work, no one was ever talking about what the biochemical changes, which can be permanent, in some people that were suffering from eating disorders. So I use it in my practice to make the patient more aware of how foods react to them and the types of things that they can do to help their body to stay in recovery.
And Donna, this is such a niche part of within functional medicine. So what inspired you to get into this work specifically, and specifically work with eating disorder patients?
So I have been a medical nutritionist since 2002. Previously to that, I was a medical technologist and I worked in the hospital for 20 years. So I had my own battle with anorexia, bulimia, mostly really like a binge eating disorder, right? Between anorexia and binge eating. And I had gone through that at 15, 16 years old. So that's 1972. And I felt at the time that, well, at the time, at least they had an idea. The doctor that I went to told my mother that I had depression. And back then there was no discussions of depression. People didn't go for therapy. If you were crazy enough, you went to a psychiatrist. And so I realized myself that the eating disorder really had a hold on me. And I believe, and I still believe, that eating disorder is an addiction. And according to all the big facilities, Renfrew, Montanito, Asana, they say, no, it's not an addiction. And my answer to them is, well, then you've never had an eating disorder. When you can't stop behavior and you cry to stop, you're addicted, right? And so to break the cycle, it's really difficult. It's difficult to break the cycle. So that's really what catapulted me into understanding more about what happens to your body when you're going through it. What are the long-term effects, right? So we have a lot of eating disorder behavior now. All these young women, I feel we're going to have a major bone loss component in the future. A lot of women don't eat dairy, cut out dairy. They're always, starving, overworking out. And I try to tell them when they're young, you need to protect your bones. Your bones are building until you're 26 years old. If you don't do bone health from the beginning, lay down the amount of bone, you're at risk just from the beginning. And then when they're not eating, of course, you're in a bigger risk. So it was really feeling like, what did it do to me? Not only physically, mentally, right? That was a big part of what it did to me. And just trying to see how I can give women or guys, because it's men too, give them that little extra edge about things they can do to help to stay in recovery, because it is recovery and they call it recovery, yet they won't call it an addiction. And I have a problem with that, because to me, there's no way it's not an addiction.
And that recovery is more of a long-term thing, almost like a lifelong.
I can honestly say at this age, I'll be 68 in September. I'm fine, right? I've been fine for the past at least 40 years. It just, I eat organic. I'm healthy. I feel good about how I take care of my body. So I don't have the problem, but it becomes so psychiatric sometimes with the eating disorder. Patients feel that the food has control over them. That's not reality, right? The food doesn't have control over you. You have control over the food. But that's the twisting of the mind that can happen when you're in the thick of it.
And is it, Donna, that when you heard your provider say that it was depression in your case, I wonder if it was that curiosity that made you think, well, it's not, that doesn't resonate with me. What else is going on physiologically that made you want to do this work specifically with nutrition?
In 1972, they didn't know about a lot, right? Like, I mean, at least I think the doctor for that time, he was actually ahead of his time to connect the mental health component to it. Mm-hmm. So when we think about eating disorder behavior, it's a coping mechanism. It's not the main diagnosis, really, right? It's a coping mechanism. Why do people use food? To cope with anxiety, depression, OCD, feelings of self-worth. When I have worked with younger groups, I've spoken in schools, try to educate young people about it, talk about what's against them, right? So you could open a magazine and you would see the perfect bodies, size 2, right? And then of course, now in modern society, everybody's snapping and selfies, and no one takes a bad picture of themselves. So that's not even real. Like, that's an overinflated way that humans even look. So that makes it extra worse for them today, because they have all that social piece. I didn't have that in my time, right? But it wasn't rare. Even when I graduated high school, 70 to 74, I'm in high school. We all used ice cream if we broke up with a boyfriend or whatever. We would sit there and eat the whole half a gallon. It's not that it's new. It's that now there's a lot more going against the patient because we're in a different place.
We're in like a whole new world with the internet and social media and how many lives we can see a day just from scrolling on a platform. And it's definitely very different.
Yes. And it's not just the aesthetic piece.
And the images too, right? Sometimes you don't even have to be fixated on a picture. It's like the images that are popping in your head about what is reality.
And also on all social media platforms, not even just like imaging and aesthetics, but also like the fear around like toxins and like certain ingredients in food. And like, you have to be following this diet and that diet, and you got to avoid this in your water. It can be overwhelming. And I feel like it can kind of put someone in more of an obsession than being proactive about their health.
Yes, I agree with that. When I see my children patients, I see 2 and up, and I never have the first session with the child present. And parents are like, well, that's interesting. Like, why? Because children or adult conversations are with adults. children need to be protected from those conversations. So if I've food tested a child or whatever we're doing, when I've already made the treatment plan with the parent. So when the child comes in and I tell the parent, it's all positive. Not this is terrible. It's like good news. We found out how we can help you, right? Because children can take some information and they're also well read, a lot of them, and they'll go on the internet and find out they think they're in serious, worse trouble than they are, right? So you always want to protect the little ears of what they're hearing because it's powerful.
And I'm glad you're bringing that up now, Donna, because I would like to touch on orthorexia because so many of our health-minded individuals who are interested in what we do may be at higher risk of orthorexia. So if you don't mind, can you talk to us about what is orthorexia? What are you seeing in practice, and how can we really strive to achieve optimal health while preserving our mental health?
I think it's important to remember anything could get out of hand, right? So when someone is coming in and they're tracking everything they're doing, and often, believe it or not, it's the pediatricians who put the children, they want them on the trackers and for counting their macros. And I'd say, no, if you're having a problem already, we don't give more tools to fuel the problem. But with orthorexia, it's such a big pull in this country because let's face it, the food has become contaminated. It's scary, but you can't make yourself crazy either, right? So you could worry yourself to death. That will kill you too, right? So I always try to tell the patients, just be realistic. Be realistic. Like I always tell my patients, I believe everybody should have one decent, healthy dessert per day. And we can pick it from the healthy pile, right? There's plenty of good stuff. We make a lot of stuff with Simple Mills and different companies. Yeah. But there's this idea that you can't put a drop of sugar in your body. It's an unrealistic goal. And when I remind them that the fuel source to their brain is sugar, they look a little confused. So if all the sugar was out of your body, as if all the salt was out of your body, you wouldn't be alive because your body needs it to function. So it can get crazy with people being, they won't eat anything unless it's organic. And the reality is sometimes that's not going to be a possibility. And you can just try to do your best as you can, but don't make yourself crazy because you're doing more damage with the crazy part.
And actually, this brings up, what comes to mind is like blood sugar regulation when you're bringing up sugar and the restriction aspect of it and how it's so necessary for our brain. Does that play into one of the physiological causes of eating disorders if someone's restricting sugar for a long time, or what else could be a physiological cause?
So physiologically, so let's take this time to talk about the physiological changes that I have seen. When one of my favorite descriptions, because it really explains it well, is when someone's bulimic. When I explain to them, when you put food in your mouth, and for some people, it's even the smell of food. When you put food in your mouth, the digestive enzymes start to get the release right in the mouth. The stomach is preparing for the food. So here we would have a release of insulin. Leptin can start getting going, right? And so if someone takes the food in, and when someone's bulimic, they're not holding the food there for 3 hours. If someone's going to be bulimic this way, vomiting, because there's also laxative bulimia. If they're going to be bulimic, they're going to get rid of that food relatively quickly. And so one way to know if you have a child that was doing bulimia is they would leave the table, right? They're going to get rid of it. But the problem is that the hormones that were preparing for the meal have already been released. So often the insulin, the leptin, these are already getting released. So what happens is if you get rid of the food, your body's confused of, wait a minute, where's the food? We already released the hormones. And that can be a permanent metabolic shift in a person's body where after they finished having if they were able to conquer the bulimia, that they would be left with this hyperinsulinemia response. I actually did a study on one of my patients. I mentored her. She became a nutritionist at the Mayo Clinic.
Wow.
And she went from like 130 pounds down to 85. She had to go inpatient. I did some work on her, some studies where we did a 6-hour glucose tolerance test on her. We checked her fasting, her glucose, her C-peptide, and her insulin. We gave her the 100 grams of sugar. And then we checked her for over a period of 5 or 6 hours. In her second hour, after she had the 100 grams of sugar, her sugar dropped to 60, her glucose, and her insulin went over 100. And so I did a couple of patients like that because I wanted to see what were some of the biophysical changes in the body. So that's a good example of a person that had some changes because of her anorexia. Sometimes it doesn't go back. You're stuck like that. So how would it manifest as you get older? That person could be hypoglycemic in their life because of the early eating disorder behavior they did. That's one way, insulin, leptin, that can be. Mostly it's that. The other physiological changes, this is sad, is some of the people that are bulimic, if they've done it, I mean, there's patients that are bulimic 6 to 8 times in one day. What happens is the hiatal valve, it's confused. So I explained to them, it's never normal to vomit. The reason we vomit is a protective mechanism in case we had a bad food. But when you force that valve to open in the opposite direction, one, you increase the risk of that patient getting SIBO infection because it's like a backwash where you're sucking things the wrong direction. And then the other thing is, even after they've gone through treatment, it's very hard for them to hold food. That the hiatal valve, it's on a hair trigger, like if they could throw up just without even trying. And that's a tough one to deal with. So sometimes they have to work with feeding specialists, which help them to try to retain the food, to try to fight the urge that it's going to come back up. It's a big price to pay for behavior that was done.
And with that blood sugar dysregulation and the issues with leptin and insulin, what happens, or I guess when you take patients through a recovery process, I know you were kind of saying how they can struggle with hypoglycemia kind of long term for the rest of their life. Have you seen in some patients that it is reversible? Or what are some things to try and help
Right.
that?
Some people it's reversible. Sometimes it depends upon how long you've done the behavior, right? So let's say somebody just did it for a month or two. Usually they're not going to have the long-term effects. But if someone was into it longer, certainly a year, or some people it's years, it's often it can become permanent. So what would happen if a person became hyperinsulinemia? You would have to create the food plan. They would have to eat often, right? So every 3 hours, small amount, but it would have to be getting a good amount of protein and fat to discourage the insulin release. Sometimes I'll use certain nutrients like alpha lipoic acid, zinc, things like that can also help their body balance the sugar. There are glucose manager type supplements that can help, but really it has to be the dietary switch. So could we go as far to say is that early eating disorder behavior may be a precursor to type 2 diabetes? I wouldn't be surprised. When I explain to the patients that you are born with so many beta cells, period, you can't get more. You use them up, you waste them, they're gone. And that's often when a type 2 diabetic would end up going on insulin because they don't have any. One of my favorite tests to run, I wish more doctors did it, but I rarely see it, sometimes endocrinologists, is the C-peptide. Because if you run that along with the insulin and the glucose, you can see what the pancreas is doing. So people have C-peptides way over the 6 or 7 upper limit that it is. You know that that's an insulin wasting situation. And if we don't get a handle on it, that person likely will become type 2 diabetic. And sometimes, interestingly, the blood sugars are still normal. So they fall under the wire where they go once a year for their physical and they say, yes, everything's good. In actuality, that patient is on their way to type 2 diabetes and has no clue.
Interesting. But Donna, what about preceding factors or patterns that you see in other laboratory testing, such as, I know you're interested in genetics, COMT, SNPs. Do you see these types of things in eating disorder patients or hormonal imbalances? I think about HPA axis dysfunction or adrenal fatigue is commonly known as such a big issue. What kind of patterns do you see?
Right. And of course, in traditional medicine, they don't believe in adrenal fatigue, right? There's no such animal. They'll get there though, because everything that I learned 40 years ago when I started going to holistic medicine, we called it holistic, then it was integrative, now it's functional. Everything that I learned, and I was lucky to train with some of the greatest early gurus of functional medicine. So it all came out to be true. What other field could you say that they had the information before we even had these biotech companies that were able to provide the testing? It's amazing to me, right? So when you see the adrenal fatigue, the closest that the traditional medicine comes to that is they're going to call it POTS, right? Postural orthostatic tachycardia syndrome, because that's something feasible they can put their hands on. If they can hook you up to a blood pressure cuff and you're laying down in the supine position and then you stand up and you drop, your blood pressure drops, your heart rate goes up, your blood pressure drops. They're going to call that, right, POTS, which is really adrenal burnout. So anybody that's had ever a chronic fatigue syndrome, feel weak in their walking position, they're most likely in adrenal burnout. So if someone's battling a eating disorder, I can guarantee you they are adrenally burned out, because it's like when you dabble with behavior, you don't realize how it's getting a hold of you. And when I have the young kids that I see, maybe they're 10, 12, 14, I explain that to them. This is a sneaky son of a gun, and you may be playing with this behavior thinking harmless, or maybe you only bulimic once in a while when you overeat. But if you get other stressors in your life and you're using a behavior that can relieve anxiety, that thing can grab you like a hook and pull you right down, because you're already familiar with how to get relief with that behavior. So that's the danger when someone's dabbling. With hormonal, most of the girls that I've seen, mostly girls for this one, they would have, well, often if it's severe enough, especially in anorexia, there's no period, right? The body's going to stop the period in hopes of preserving that extra blood it doesn't have to lose. But commonly, I would see both estrogen and progesterone deficiencies, and follicle stimulating hormone is turned off. So I've seen that in anorexia, where, think of menopause, the follicle stim is going up, right? You're increasing until you hit the period's done. And sometimes it never retreats. I see women stay over 100 in their FSH, even in past menopause. But in the anorexia presentation, I've seen FSH go down to a 1, where the body just turned it off, right? So with these hormone deficiency at that point, no estrogen, no progesterone, often no testosterone. What's happening to the body? Serious aging and bone loss is going to be coming your way, right? Because we can't have that. Interestingly, if you look at the medications that are used in the facilities, it's SSRIs are the first drug of choice in eating disorder. And if you look at simple, like a Prozac, Lexapro, those types of drugs, Zoloft, they increase the progesterone. And that's how it exudes the calming effect. So even in menopause, they're using Prozac now, and women get annoyed. They're like, well, what are they giving me that for? Like, I'm not depressed. I said, because it's working in the endocrine system. And if you take a low dose sometimes of that kind of drug, if you couldn't get relief elsewhere because they don't want to give hormones anymore, the person could get relief because of the increasing of the progesterone. So, and it can really help with the sweats. I like the bioidentical hormones. That's what I use for myself and my patients, and we test. So I feel comfortable. You never just want to think about the woman going into a grocery store, picking up whatever. Some of those are estrogen, right? Like black cohosh. Others are more towards the progesterone, but you don't really know what you're doing. And so I like the saliva testing because you get 4 samples in one day. For my patients that have severe PMS, which can also be going if they are getting a period with an eating disorder, I try to capture the levels as close to the period as possible. They have the kit, and we get as close in there as possible, day 25, 26, if they're running a 28-day cycle. That's when you can really capture the major hormone imbalances that I see. A lot of even young girls are estrogen dominant right before the period. And then you see the real manic, psycho, depression, anxiety behaviors.
And when you're running testing, Donna, do you see a lot of links between like certain nutrient deficiencies or even other markers in eating disorder patients?
So commonly, one of my favorites to go look at would be, of course, the zinc copper ratio, right? So if somebody, zinc we know is the mood mineral, if they're copper dominant, especially a lot of women that have these IUDs that are releasing hormones, or they're on a birth control pill, right? Copper dominance will increase the anxiety. So I'm looking for that. I'm also looking in the food testing that I'm doing. I'm looking to see what are the opiate responses to the gluten in the dairy. Because think about if someone has which I'm saying that I believe eating disorder is an addiction. If someone has an addiction where if they crave sweets, cookies, cake, ice cream, is it okay if someone just ate 2 cookies? Yes. But if they tell me they get the bag and then the whole bag is gone, they don't even remember eating it, that is very suggestive that there's an addictive property there. And so when I test the opiate responses to the gluten dairy, can be soy also, if they have a lot of opiate response, I try to explain to them it would be similar to someone having alcohol problem. You couldn't tell that patient, well, just you can have a glass of wine, because they can't. What's exciting about understanding opiate responses, I believe in the next 5 to 10 years, we're going to have alcoholism much more figured out, because if it can come from food, which all alcohol comes from food, that there would be an opiate response. I believe the same is going to be true for alcohol. And then because when people have alcohol problem, their answer to even 12-step programs is, I'm powerless over this, right? I'm powerless. I would never want to feel that I'm 100% powerless. That's why I don't like Overeaters Anonymous. But for many people, it will work, right? They measure everything they do. They have to believe they're powerless. In the beginning, I would say I was powerless, but I would hope that as I got my tools, got my body healthier, learned more about what my triggers were, that I would be able to be in a stronger position than just say I'm powerless. It's a point of weakness. I just don't love that approach.
And going back to a little bit earlier, you did mention adrenal health and how the adrenal system definitely takes a big hit with these types of conditions. What are some of the steps that you take to support the adrenal glands from the start?
All right. So if we're doing testing, I really prefer the saliva testing, because that gives me a good picture 4 times a day what's happening with the cortisol and the DHEA. So what I see with a lot, especially moms with children, boy, those cortisol shoot up after 5, 6 p.m. and to use to support in functional medicine to support the adrenals in any kind of mental health situation. Of course, unless there's medications, you have to be careful. It would always be in the patient's best interest, if especially when you see the DHEA is depleted. The cortisols are either very high or they've already wiped out and they don't have any. It would be a good idea to support the adrenal health. Sometimes it's done so gently, easily. I don't do anything aggressively. I'm very, very cautious in what I do. So I would do it in a way that's simple. We could use some vitamin B5, pantothenic acid, some vitamin C. I would give the patient, as long as they don't have hypertension, a couple of cups of licorice tea per day, maybe a little green tea to try to increase some of the theanine, and just kind of gently coax into it so that you don't throw somebody in a tailspin, because sometimes a treatment plan could be too aggressive in an already fragile body.
And go ahead, Emmy.
I was just going to ask, what about sleep, Donna? Are you focusing on sleep at all as far as
Crucial, right?
nourishing adrenal glands?
And I can think back just being a child. No one had a sleep disorder. 10 o'clock, lights out. There's no TV. There's no lights on. There's no phone. So everybody slept. So now you have, especially the young people, they tell me, even when they're as young as 13, that their social life doesn't start till 9 or 10 p.m. So they're on their social media. So I just have to tell the parent at that point, you got to take the phone. If it's 10 o'clock, they have to be off. Weekend, you give a little leeway. So sleep, if you don't sleep properly, you're not detoxing, you're not storing your nutrients. And I use a lot of description of circadian rhythm, and I take them back, whether it's a child or adult. Go back to when we were farmers 100 years ago. People had to get up with the sun. The meals were hearty. They went to bed when the sun went down if there was no lights, right? Because there wasn't a lot of option. And that really respected the circadian rhythm. So people say, well, I can take a nap here and there. It's not the same. You have to sleep when your clock is in that window. And everyone knows when they sleep, they feel better. So interestingly, I just even read a very great study from Harvard University that they were looking into calling bipolar as a sleep disorder. If you look at what happens when someone has to be admitted psychiatrically, usually people go for 1 week. They're not going to figure your whole body out in 1 week. That's for sure. But what would they do if someone was in a manic phase? They're going to sedate you. So we know that when you sedate somebody, when the brain is all hyped up and it's misfiring, that if you turn it off, much like the computer, the brain can rest and almost reset itself, right? And then they're going to start medications. But honestly, 1 week is just not long enough to know what's going to do anything. I think the biggest benefit when someone goes in patient for psych is that they're off the grid and they're sleeping. I really think those are probably two of the most recovery strengths, is because you have to get out of the craziness.
Speaking of the craziness, Donna, this is a good segue in terms of the evolution of the social impacts, as we touched on a little bit. So social media influence, even the body positivity movement. So I think there is some benefit as far as working in today's environment. Intermittent fasting is another one, though, as far as influencing maybe folks to take it too far. So I'm curious, what are you seeing and how do you manage these challenges, the ones that are proposing issues for your patients and clients?
I think with the intermittent fasting, sensibly, because what ended up happening, people end up eating round the clock with their social media, right? They're up 2 o'clock in the morning, they're eating. Intermittent fasting simply overnight, right? So say something from a 7 p.m. to a 7 a.m. Unless someone's diabetic on insulin, that's never going to hurt anybody. right? But my patients that are on insulin, type 1 diabetes, they have to have their snack before they go to bed, and we pick good, something good, right? But to rest the gut overnight, that's not harmful because your body needs a rest. It's not supposed to be digesting 24/7. It needs a break. Digestion takes a lot of energy. And if you keep it going 24/7, the rest of you is also going to take a hit because you need to rest the system. When people are going days into intermittent fasting or doing something, the different patterns, like they're eating only between 12 and 4 p.m. or 4 hour, 8 hour window, I would say you have to really see how you feel. I would think would be the best thing. If someone is underweight, of course, we can't have intermittent fasting for that person because at that point it's counterproductive. They're going to be into their lean muscle mass. So that's a bad idea. But I think at least a 12-hour overnight for most people, if you're relatively well, I think it's okay. You know, a lot of people, I mean, even when they spend their time with me, my first session with a new patient is an hour and a half because it takes time. You have to go through all the different components. But they go Google and they research. So, you know, when I am advising them, I make them sign a waiver that if you start doing stuff on your own alongside of what we're doing here, I cannot take the responsibility because at that point you went off the grid. You went off the rails. You're doing whatever you want to do. So people are well read today, easy when you can go Google anything. I know my colleagues that are doctors that are not into any kind of functional medicine, they're not happy about it because they feel that the patient comes in actually often more educated on the topic than the doctor, right? Because they've researched everything. So you have to be careful. I only have a few trusted websites. I don't trust them all. Anything that's strictly leaning towards pharmaceutical support, it's giving one side of the picture. So I like to read peer-reviewed studies. I like to read information that is just giving a more broader sense of what possibly could be influencing a person's medical condition. Another big one I'm not a fan of is people talk about the medical medium. That person doesn't see you, doesn't know you. That's cookie cutter medicine, the same as what we got going in our traditional medicine.
Great point.
And all of these people drinking the celery juice when they have high oxalates and different things in their body, that could be caustic to some. Yet I'm not against celery because I throw 2 stalks in my protein shake every day because I love it. So you have to be cautious anytime you read something in a book. No one has seen you personally, individually as a patient, and they're giving you medical advice. I'm not a fan.
And Donna, you made me think of when it comes to supporting your patients like through these challenges, do you often address other things that are not just nutrition and labs, but more so like lifestyle factors, like whether it's exercise, relationships, their environment, support system? I know your website did mention like lifestyle coaching, so I want to hear a little bit about that.
So what I've done is because I realized early on that our personal habits go deeper than just the food. So I've aligned myself with at least 10 therapists. So I have different kinds of mental health therapists and a psychiatrist that are there's different types of therapists. Like one of my therapists, he's a Christian type therapist, right? Then I have therapists that handle different kinds of situations. So I always try to, when I'm going to refer out, make sure it's going to be a love connection, because if you can't connect to the therapist, we're not getting anywhere. So when the patient comes in, part of my inpatient history that I take in person is we talk about not only your early medical history, when you were born, were you a well child? Are you happy? Right? Are you happy? Because if you're not happy, it's not just in your brain that you're not happy. all of your cells are going to pick up the message that you're not in the right place. So one of my biggest things that I'm excited for is 2 years ago, I was published in a book called Crazy Girls and Guys. My sister-in-law wrote the book. So she was straight up social worker, big practice, and she was big on the pharmaceuticals strictly. There was a drug for everything. And while we didn't agree, we always were fond of each other and respected each other's work. When her daughter got sick at 14 and went the traditional medical route, she was probably on 50 psych meds in a couple years, and she didn't get better. The sister-in-law came to me and said, "What do you got?" And unfortunately, most of my patients, a good portion, come with that. They're just done. They've been thrown away. Nobody's helping them, and they want to go deeper. And so she published, I get like 2 pages in the book, but my whole point of what I said in the book is that we have to stop thinking that mental health is here. This is a piece, right? A piece. We have to look at the whole physical body, what's going on in that gut, other things about our social connections. Is your child being abused, bullied? You know, even when you go to the doctor today, they'll take the child aside and ask the child if they feel safe in their home. So we're starting to make some connections. So yes, we talk about how you live your life. Are you happy? I believe you need a spiritual component. Doesn't matter what it is. You could be praying to the universe, something bigger than yourself to ground you. I believe in that. We talk about the relationships. Often people say to me after we've had this session, like, I feel like this was like a therapy session. And then I have to remind them, I am not a therapist.
Right.
I cannot counsel you because I'm not licensed to do so. But I can tell you that these things are bothering you and you need to talk to somebody and either find someone on your own, or I can give you from my list people that I know personally that I feel comfortable with that can help you delve into the problems, the issues, the baggage, whatever's going on, especially when it comes to food. A lot of people bring up in this session that, well, they were doing just fine on their food plan till the mother-in-law came. So I say, what's the connection with the food? Well, she annoyed me. What's the connection with the food? And I make them realize that they're using the food as a coping mechanism. That's when we connect. And my advice to them, and I work on this to help them, is just like you brush your teeth, you wash your face, nothing gets in between you and your health plan. It can't. So no matter what happens in the outside world, you can't come home and eat a pizza because then you're punishing yourself. And that's not an acceptable way to deal with stress. So I would say out of the amount of patients I see, about 30 a week, probably 15 of those have to go to therapy because there is a big connection to using food and coping with stress, especially when we know about all this opiate response with food. People are using it for comfort, just like they would have a drink. They'll go home and do whatever with the food. Most people do relatively decent during the day with their food, but boy, after work, they just fall apart because they either feel that they deserve it, right? I had a hard day. I worked really hard.
Yeah.
I know, but it doesn't give you the door to open to eat the box of cookies. How is that helping you? Almost every person that I've worked with, and I've seen thousands of patients, have said to me, when we change the food to more healthy, I think maybe 5 people out of 1,000 told me it didn't matter whether they ate hot dogs, orange soda, ice cream, donuts, or they ate healthier meals. Only about 5. Everyone else acknowledges, I feel better. Yes, I feel better. So they know it. But again, that addiction component's coming in. Most people, many people say, have disordered eating, but not everyone has an eating disorder. It's like when you come home from work, if someone has two glasses of wine, is everybody an alcoholic? No, they're not. But they're still using the alcohol to calm, soothe, feel good, right? Where does it cross over into the next level? That's usually con- connected to the other comorbidities that are happening in the person's life. How much anxiety, depression, OCD, self worth, all those things.
Right. And in that way, would you agree, Donna, that the eating disorder at that point has become a symptom of those deeper issues? We say
Yes.
comorbidities because the eating disorder in itself is a morbidity, but it seems
Yes.
that the root is oftentimes, as you said, anxiety and
Yeah. And
depression
I
and self.
think from the physiological standpoint, it feels good to starve.
Mhm.
People don't realize that. When you don't eat, you're like high. And think about it's not all bad with that. Think about monks in the Andes and all these people. When they go into their meditation, sometimes they don't eat for 30 days. They would be drinking water, herbal teas, things like that. But they're able to be out of the stressful environment. They're able to slow their breathing down. So they're using a lot less breaths per day. They can actually slow their heart rate. You're not going to be burning the calories, right? Because you're in a very meditative state. That's different than it reminds me of like a lot of people say, well, I want to detox. You can't detox and go 90 miles an hour. You need to slow down,
Mm-hmm.
right? You need to do some meditative state here while you're going to be doing this detox because it's not healthy. It's like when someone's in adrenal burnout. Is that the best person to detox? No, because it's going to be an extra stressor on the physiological body.
Right. Yeah. And I think that taps into being addicted to our stress hormones, which we have touched on before on this podcast, and kind of grind
Yes.
culture, which is a conversation for another day, but important to mention nonetheless, I feel. And there's so much to unpack here, obviously. I think it can be intimidating for practitioners who want to do this work. And as such a seasoned professional with so much experience, Donna, what advice do you have for practitioners who want to do this work, but they don't know where to start? They don't know how to build their team of mental health professionals to refer to, for example. What would you say to them?
Well, I would definitely say that if you are going to do eating disorder work, anorexia, bulimia, and you're going to take the assessment, you have to understand it's going to be a physical, mental health assessment. And you could just tell by people's presentation how nervous they are when they come in. You have to have a therapist on board. I
Mhm.
won't work with anybody who's big into their problem without a therapist because it's really not a good place to come from. There's a saying in eating disorder work when the eating disorder starts to get controlled, that's when the mental health issues escalate. So you take away the coping mechanism that the patient's using, expect to see more emotional stuff. You can crash them really
Yeah.
mentally. And that's why you need the mental health
Mm.
expert. Also, the other part would be knowing when to call it. Like I have brought people into the practice or, that they came as a patient, usually family brought them. I told them from the first session, my goal is to get you in treatment. I can't keep you at this level. It's A, not ethical. B, you need a higher level of care. So to make sure that you lay out your plan, because you can tell who's in trouble. Really, it's pretty obvious, right? But you lay out your plan from the beginning so that you don't blindside the patient. That my goal is to get you into treatment. Some practitioners won't even see anybody that's shaky in their disease. I want to give them a chance, but they know that number one is there's no weight loss, not 1 pound. But they also know that she's going to get me into higher level of care. Unless they can do it. And I tell them, I'm going to give you a chance. But if you can't, this is where you got to go. The other thing I would think to be important would be is to either align yourself with a functional provider that can provide the testing of what's happening to the physiological body, so that you could either have someone handle that part for you so that they can be addressing, just from going through an eating disorder adrenally, that person's in burnout because it's a very, very stressful. When patients, right before someone goes into an in-treatment program, they got to break. They got to hit the bottom. And I know it's time when they break down at the session crying that I can't do it anymore. I'm done. And then I'm like, okay, let's go. And I already have the place set up, right? Because you're always thinking ahead that they're probably not going to make it at the level of, like, my level is outpatient, right? They're not going to make it. So I've already done my outreach work. I already know who's going to take them. We've already checked insurance. We're ready to go, because it is a defining moment. And that moment is, boom, they hit the bottom. Let's go. So that's important. And usually it's the emergency room, depending upon what's their level. If they're going to go into anything inpatient, they have to go to emergency room and be stabilized.
And Donna, I do want to ask too, we've touched on women in this space a lot, and that's kind of what comes to mind when we think of these disorders. So what about men? What about men in this space? Do you work with men? Do you work with primarily women? What's kind of the differences?
I do work with men too. They're much more secretive and embarrassed, I think, by it. Because if you think about men, again, the social piece of it is men should be big and strong. And I feel that there's much more of an embarrassment for the men. But again, same idea. If they can't be able to think of, if someone's bulimic, what's the comorbidity there that I've seen? One person comes to mind: mom's an alcoholic, having orange juice and vodka 7 o'clock in the morning, grow up like that. That kid can't hold food. It starts with that they throw up because they can't handle what's happening in the home. And then this becomes a bulimic situation. But you see the embarrassment, you see the much more disgust about their body. Like, I'm a man, I should be able to handle this. So I think men actually fall through the cracks a lot more than women do. And it's harder to get them into treatment. It's really not easy to get them into treatment because it shows weakness as far as men are concerned. So they're more risky, according to how I feel about it.
Yeah, I can imagine. Well, thank you for sharing some light on that. And before we wrap, I do like to end each episode on a really positive note. We've gone over so much today and went into a lot that we haven't touched on yet, but I do want to ask you, Donna, what does it mean to you to live a vibrant life?
That is a great question, because when you ask me what I say to my patients, do I encompass the whole thing about wellness and health and happiness? I have two definitions of what it is to be happy. One, wake up in the morning happy to be alive and thank God for the day. That's how I feel. My second thing is, when I put my head on the pillow at night, appreciative, grateful, and thankful for what I brought into this world. That's it. That's all it requires for me. Those are my two definitions of happiness. And I'll say to the patient, what is happiness for you? Because if you can find your own peace and happiness, you don't need outside things to make you happy. It's nice to have stuff, right? It's nice to travel. It's nice. But that's not really what happiness is about. It's your self-fulfillment. And even when they're going into their careers, if they're young, you have to do what you love. Then it's not work, right? And if you feel like you've made a difference, you want to feel like you made your mark, especially that comes as you get older, definitely past 50, you start to realize, did I accomplish the gifts that I was given? And that's it. That's really what it means to me to be happy.
That's amazing. It is so much deeper than just like an external environment. And to our listeners tuning in today, Donna, if they want to connect with you, where can we find you?
So you can either reach me on my website. It's www.functionalmedicalnutrition.com, or you can email me at backtobasics.dg@gmail.com. And I would be happy to talk to anybody that would like some more information.
And we'll be sure to link your website down in the show notes just so that everyone has easy access to it. But thank you so much, Donna, for bringing so much to this episode today. Again, we haven't really touched on this topic too much on the Vibrant Wellness podcast. So I think this is going to be a really good resource for our listeners and to everyone who tuned in. Until next week, wishing you all vibrant health and wellness.
Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness podcast to discover the latest insights and strategies for optimal health. Join us again next week. Just a reminder, this podcast is for educational and informational purposes and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guest and host are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.